Good morning, everyone. Thank you very much for coming today. So I'll be talking about why we choose the heart failure, because probably I'll be talking about the QCG experience, national, international guidance, as well as personal experience in this field. So I would like to draw your attention why we be talking about this. So this is a very nice paper published one of the more prestigious cardiologists in modern area, Eugene Brownvall, about the war with the heart failure. And this is the huge problem across the world and across our Western nation. We've got about almost 40 million people per year diagnosed with heart failure. Majority of them prognosis, believe it or not, is worse than the cancer. Our community recognizes very well the cancer is a bad diagnosis for them, but I'm not so sure whether I'm aware that the patient diagnosed with failing heart has got even worse prognosis. This particular paper was concentrated to find a new technology to improve heart muscle function based on the gene therapy stem cell transplant. They're a very early stage, and I will be talking about this. I'll be talking more in general term about existing possibilities, how we can treat the patients. So, believe or not, this is so common that if you're looking for our population, and probably majority of us are over 40 years of age, so 2 out of 10 of us might develop heart failure in our life expectancy. This is common with becoming older, especially in the ladies. And these days we always saying the ladies coming with the shortness of breath above 80 years of age. Very likely this is due to cardiac problem than anything else. This is the national data published in the US. And we might think that we've done a very good job over the years reducing mortality. It's actually very disappointing. Mortality is still very high. We used to say the patient, probably 50% patient might die in 5 years of observation, and this information is still valid. However, the prevalence and incidence is different, is more often diagnosed, patients live overall longer, perhaps may be treated with the cancers successfully and develop the heart failure in their life. What we achieve significant reduced patient and hospitalization, especially mortality patient admitted to the hospital. So definitely this is a big advantage of the modern medicine, which bring the patient better outcome while in the hospital. But we didn't reduce the incidence, patient more diagnosed and more often come to the hospital. So we all be facing on this sort of problem. Whatever we're doing in the medicine, whether we're doing not related to the general practitioner medicine, whether related not to the internal medicine, we will all still have the patient with failing heart in our rooms. So in order to tackle this problem, in order to have some clear guidance how we should treat this with better patient outcome and prognosis, there are a few bodies around the world, including the United States, which publish some sort of information, concrete information, which we can use for better outcome of the patient. And it was published in 2013 with the American College of Cardiology and American Heart Association. Soon after that, published this year, extending with the patient with the Society of Heart Failure in US. It's very interesting because this body is not based on only purely cardiology. It's actually majority of the people who create this are general physician, thoracic physicians, including the nurses. So it's a very wide body for the people who are working this area and getting the whole information for us. So after many years to know that the heart failure exists, we make the final decision what should be diagnosed for this. So this is very complex disease, which involve both or either structural or even functional only changes, so it could be reversible. And this is relating to the impairment of the filling ventricle as well as ejection of the blood. So this is a very wide spread of the disease. Regarding the symptoms, they are very atypical, and I always saying this, probably I failed my first exam in medicine because I will be asking about patient symptoms and I start from the fatigue and shortness of breath. But this is the common problem. And patients for atypical symptoms, very difficult to distinguish with something else. Of course, if the patient got the fluid retention, congestion, we diagnose patient with congestive heart failure. And this is not a disease, is not only due to myocardial disease, could be all other problems could contribute this, certainly the valvular lesions and the endocardial lesions as such, fibrosis, pericardial disease, could be purely for the metabolic syndrome. Patient might have the sepsis and might develop the heart failure because of that, which could be reversible. So numbers of problems in heart failure doesn't mean that the patient got the cardiomyopathy. So I like this slide because this is showing us how the disease is progressed. So this is progressive disease, and very often got this spiral cycle, which is irreversible and leading to the, to the palliative care or patient death. So over the time, patient might have some hiccups, worsening symptoms, worsening ejection fraction very often, recover, coming back, and more often. So we know about that. I would like to stop this cycle to prevent this readmission to the hospital, which are extremely costly, extremely difficult to manage patient, very disappointing for us to look out at the patient recurrent to the hospital, recurrent to see us, complaining the symptoms. So this is something which we are not very happy. And I think this was one of the reasons that the body which I mentioned about you before recognized this, that probably we should diagnose a heart failure with a patient got no symptoms whatsoever. And this is the new stages of the heart failure, which has been recommended by the American College of Cardiology, and this is stage A, B, C, D. So there is no relation between stages A, B, C, D and functional assessment, but neuro heart association classification. You can see here that actually in stage A and B, patients don't have symptoms whatsoever. So we identified the stage A patient which don't have any structural changes but don't have any symptoms, and they only have the risk develop, because this is the area which we can tackle, which we can prevent the develop the further stages, which are very often irreversible and as I said, very difficult to manage. So it's very important to define patient stage A, B, which are already some structural changes, but patient denied any symptoms. I found this very difficult in my rooms, and probably you got the same when you see the patient don't have any symptoms, and we are talking about heart failure. Patients start to worry about this. But I think this is a very important point to address this early stage to get the patient possible the better outcome. Certainly if the patient got the symptoms, we know very well from 1 to 4 neuro heart association. They're usually in stage 3 with already significant structural changes, so the heart muscle dysfunction, valvular lesion, myocardial ischemia, coronary disease, and all these problems. Stage D is usually leading in these days to the palliative care, very rarely, certainly sometimes they might lead to the cardiac transplant in the patient's lucky, relatively young age. What we recommend these days is that we should more widely use the biomarkers for myocardial, for the failing of the heart. And this is acceptance at the moment, widely acceptance that we should use the BNP or NT-proBNP for them, mainly from the prognostic benefit and for the diagnosis, not for the management. For the management are useless because they could be still elevated, patient is well treated and doesn't mean anything, but for the prognostic benefit and certainly from the for the initial diagnosis, they are one of the important parts. And then you can see that in green color, this means that the class of indications it's very high. The yellow and red means that it is lower. They'll probably be becoming new markers which might be developed in the future. Interestingly, you can see here in the stage A and B, so once again, asymptomatic patient, maybe got a little bit of ventricular hypertrophy, maybe a little bit of hypertension, that could be used as well for the prevention and diagnosis of the patient. So this is a complex slide, but don't worry, it's probably pretty straightforward. So we got this 4 stages and different treatment for them. So stage 8 is, as I said, it's more preventive medicine. So when you're looking for the patient, possible diabetes, overweight, possible underlying obstructive sleep apnea, possible underlying valvular lesions. So we need to do some changes in the lifestyle. If the patient got the hypertension, we need to treat this hypertension. And these days, the target level is 130/80 in the high risk of patients. If the patient got hypercholesteremia, they should have the statins as well. So looking back for today, the CT, if the patient, for example, got abnormal CTCA, they're probably on this category. They might have no symptoms and maybe atypical chest pain, not related to the myocardial ischemia, but the treatment should be involved. That's one of the benefits of the anatomical test that give us the option how to treat the patient for the better long-term prognosis. Sometimes they don't give us the guidance what we should do acutely, but for the long-term prognosis, there are better options. So the stage B, they be more sicker, so that, as I said, it probably might require bypass surgery if they got inducible myocardial ischemia or angioplasty to prevent development of the failing heart. Some of the patients might even be selected for ICD implantation. And regarding the treatment, it's the same as the advanced stage, so that if the patient needs to be on the beta blocker, should be in the beta blocker. If the patient with hypertension needs to be on ACE inhibitors and RB blockers as well. So this is actually, the group medications is exactly the same. You're always saying, try to avoid the medication which are prognostically probably not very good in the long term. So for example, calcium channel blockers, there are limited options for the patient to have the benefits. So try to use this medication, which potentially could be benefit on the future because they should be used here. So the palliative care, probably I wouldn't go too much for the stage D here. As I said, some of the group of patients might be referred to the heart transplant or the artificial heart, but usually they simply become older and require more palliative care. So stage C is more complex. Believe or not, over the numbers of years, all the studies were done according to patient ejection fraction, and the problems start from this. And so we got the patient with the impaired ejection fraction, or reduced ejection fraction, or preserved ejection fraction, these days we're calling. And the treatment is a bit different, and I will go a little bit more details in a second about this. So why we choose ejection fraction? To be honest with you, I think that the people who invented ejection fraction didn't expect it would be so popular for a number of years. If you ask any medical professional, they always know about ejection fraction. So what does it mean, ejection fraction? Ejection fraction is it's a relative stroke volume according to the patient size of the left ventricle. So you measure end diastolic volume divided by the end systolic volume of the left ventricle divided by the end diastolic volume multiplied 100%, and you got ejection fraction. So actually you have to understand the limitation of this measurement, because if the left ventricle is very small, stroke volume, so the cardiac output is low, but the ejection fraction will be entirely normal. So the patient might have the severe congestive heart failure with normal ejection fraction on any measurements, but actually the cardiac output is very low and very poor. And this is limitation of this technique. But anyway, the study was done, all the big studies, and it's difficult to change at the moment. So this is the group of patients with the reduced ejection fraction. So the reduced means that this is lower than 40%, so usually the 35% or lower. So we've got the same guidance how it was before, that the patient should be on the beta blocker, ACE inhibitors, of course, diuretics as an initial therapy. Second stage of the therapy is divided, depends on the further prognosis, further assessment. If possible, we always try to use the aldosterone antagonists, certain group of patients which are at risk to have it if the potassium is elevated or renal impairment. But regardless, we try to use this, maybe avoid to use the diuretic, other diuretic, loop diuretics, for example, Lasix, but give the aldosterone antagonists, sometimes very small dose, not 25, but 12.5 milligrams. So that's always good and good for the prognostic evidence. There's a new group of medication which we are well aware about this coming. They call the ARNI. angiotensin receptor neutralizing inhibitor, and this could be used as a replacement for the ACE or ARB blockers. And usually these days we got the agreement that this could be done if the patient still got the symptoms of the heart failure, so neuroclinic association 2, and got adequate blood pressure. It's a good option to choose this some stage of the patient. This is hydrolysis and nitrates was done by the black, I think, American people, so that's probably not related to us. And if the patient got ejection fraction lower than 35%, there are a few other options, including the ICD implantation or cardio-regeneration therapy with additional wire to pace the left ventricle from the left side, to narrow QS complex, to reduce left ventricle dysynchrony. In this way, we improve heart muscle function. I must say that sinus node inhibitors is probably a very small group of patients will be classified. Usually, if patient needs to be in a sinus rhythm and heart rate of 70 with maximum dose of beta blocker therapy, usually we achieve this with the high dose of beta blocker therapy. The patient doesn't need to be, but certainly a small group of patients must still have a sinus tachycardia and benefit for additional dose of sinus node blocker. So the next step, if the patient got still symptoms, or at least neuroclinic association 3 or 4, as said, there could be artificial heart, referred to the in Brisbane in Prince Charles Hospital for the possible heart transplant, or only palliative care, majority of the patient. So this is this new medication, this neprilyzer inhibitor, conjunction with the AT1 blocker, which we use at the moment. It's only one medication done only by one company, so we know this is Entresto, and the mechanism of action is actually dual. So this is the neprilyzing inhibitor, which enhancing all the peptides, atrial natriuretic peptide B and P, and C-type natriuretic peptide. So it's as effect of this treatment is vasorelaxation, blood pressure has been reduced, aldosterone level has been reduced as well, and possible reduced hypertrophy, and patient got more diuresis, so might require more diuretic for the treatment. And this medication needs to be given in conjunction with AT1 blocker, because it's actually increasing the angiotensin 2, and that's why this is the combined treatment with the sacubitril, which is the prodrug, and valsartan together with Entresto. So this could be given instead of the AC inhibitors with the 36 hours washout, or we can simply swap it RB blockers to this treatment. The patient got the symptoms of the congestive heart failure, at least neuroclinic association 2, and ejection fraction below 40%. But we treating with the ejection fraction 40%, relatively, believe or not, small group of patients is only 50%. Other 50%, probably from my personal experience, I think it's more than 50%. We have no normal ejection fraction or low normal ejection fraction. So how we can treat this? There's still debate about this. There's no clear guidance. Before, years ago, probably majority of us with the ejection fraction was below 40%, this gray zone area, we treat them as a impaired systolic function. Maybe it was right, maybe not right. I'm not entirely sure. There is no data about this. But definitely, it's a huge numbers of patients with the ejection fraction with normal, and the reason for that will show you the limitation of the ejection fraction assessment of the muscle left ventricle performance. We don't have the clear agreement when we should diagnose a patient ejection normal preserved ejection fraction. And this is from the right side. There are guidance from Europe. This is from this is from Europe. This is from US. You can see that there is no agreement between them. What we knew that the left ventricle shouldn't be dilated, because if the ventricle is dilated, the ejection fraction should drop down, and the patient should be treated with the reduced ejection fraction. And certainly it's very important to exclude any valvular abnormalities. The patient might have moderate mitral regurgitation, borderline LV dilatation, and probably not classified to either category. There's an effort and put effort to exclude any underlying problems, medical problems you could represent similar matter. And this is very challenging question. I'm not so sure how we can tackle this, to be honest with you. Costs, tests, a lot of tests, maybe repeated tests, maybe actually a lot of medical problems contributing to the patient with ejection fraction, but this is simply very difficult to achieve. There is no doubt the patient should have some diastolic abnormalities on the echocardiogram, and this is more common, hypertrophy, left atrial enlargement, but also the degree is difficult to appreciate. This is the slide showing us how the ideally should look the heart with the reduced ejection fraction on your left side compared the heart with the preserved ejection fraction. And you can see you don't need to be expert in echocardiography to see the difference. You can see the left ventricle is huge compared to the atria. Compared to the patient with the preserved ejection fraction, left ventricle is very small. So actually the cardiac output of the patient will be very low, but because we calculate the ejection fraction based on difference, based on the relationship to the left ventricle size, ejection fraction still could be normal. So one could imagine that the treatment of this group of patients will be entirely different because they present different manner and different mechanisms of the failing of the heart. So this is one of the confusion whether we should look for the patient with the preserved ejection fraction with different type of abnormalities which could contribute into the heart failure, or whether we should exclude them, thinking that this is actually the problem of the patient. And I think this is usually other round, so the patient get the multiple medical problems which are contributing to the failing heart with preserved ejection fraction. Certainly one comment is obesity, high blood pressure, diabetes, underlying coronary disease, left ventricular hypertrophy associated maybe with the hypertension, maybe some other issues. The huge is a proportion patient might have pulmonary hypertension. Mixture very often is related to the underlying lung problems, or maybe purely related to the elevated left ventricular end diastolic pressure. So to distinguish which patient got what is very challenging, and I'm pretty sure all of us have got the same problems in the practice, doing a lot of tests, try to establish this. Once again, probably the easiest test will be doing echocardiogram with particular question, but the patient got, for example, diastolic dysfunction, diastolic heart failure. So the person who will be reporting echo, doing echo, needs to do some effort to find whether this might be related to this or not. The recommendation, how we can be diagnosed with patient with preserved ejection fraction, and I must say these recommendations are very difficult to put in the clinical practice. So first of all, on the left side, this is well known, the measurements of the hemodynamic measurements, how often we're doing a routinely patient. I must say very rarely. There is invasive tests, risk of possible complications, and sometimes very difficult to persuade the patient will require this test, but certainly this is like a gold standard. So it's based on the echocardiogram also and biomarkers. So if the echo is not very conclusive, this is the based on the tissue Doppler, which we know that the 80% of our patients will be within this category. So inconclusive echo based on the E and E prime ratio. So they recommend patients should have the blood test or further echo examination. So in our practice, what we're doing, we actually a little bit ignoring this. We still jumping to this part and try to establish any diastolic abnormalities which might suggest presence of the heart failure of the preserved ejection fraction. But bear in mind there could be some abnormalities. The patient's symptoms might not be related to this. So it's a bit more complex and difficult. So no wonder what we found, that the cause of the death of the patient with the ejection fraction, poor ejection fraction, is due to mainly cardiac problems. They got the cardiac arrest, they might have the tachyarrhythmias, and they're dying because of that. However, the cause of the death of the patient with preserved ejection fraction is much more complex. They might have multi-organ failure, they might have the pulmonary hypertension, pulmonary embolism, they might have the infection or renal failure with multiple other problems, not only the cardiac problems, they might have myocardial infarction, also the falls, stroke, intracranial bleeding. So this is the cause of the death patient with the ejection fraction, not only cardiac. So that's why we have to treat the patient as multiple problems and treat with all other reasons which might contribute to the patient death. So that's a recommendation with the patient with preserved ejection fraction. So first of all, the most important is to treat patient with hypertension. Target these days is 130/80 for the best possible patient prognosis. They will benefit from diuretics. They might feel better, and prognostically will be better because we can reduce pulmonary hypertension of this group of patients. They might have underlying cardiac disease. It's very important to look after this. And again, apart from the functional test, I think the CT/CA is a wonderful test to pick up maybe the patient who might have an underlying cardiac disease. It's very important to treat the patient with atrial fibrillation, perhaps rate control, because if they're becoming too tachycardic or too slow heart rhythm, they might decompensate much easier. So, and they're recommending the medication for the high blood pressure, the same tablets which you use in patient with the reduced ejection fraction, except the ARNI, so the ACE inhibitors, IV blockers, beta blockers. Perhaps a small group of patients might also benefit from the use the aldosterone receptor antagonists. We use the spironolactone, especially the ejection fraction is it's maybe a little bit lower, and with good kidney function. So this is good medication, alternative medication, especially as well for the patient with the hypertension. So the patient got a high blood pressure, ACE inhibitors, IV blockers, maybe look for the possible use the aldosterone receptor antagonists with the patient with the preserved ejection fraction and ongoing symptoms of the shortness of breath. So from the practical point of view, maybe forgotten about the sophisticated blood test, forgotten about the sophisticated echo technology. From purely from practical point of view, it's very important if you get the patient with the suspected diastolic heart failure, looking for the patient stroke volume, because this is what's about. So if the stroke, if the left ventricle, the hemodynamic status, it's not able to maintain and failing adequate stroke volume without increasing LV filling pressures, patient might develop diastolic dysfunction. If certainly this is not adequate left ventricular stroke volume maintained during the exercise, for example, or during any pathology, during the surgery, for example, or during the infection, and the filling pressure cannot increase further, the patient decompensate and become very ill. So that's why all the treatment is to improve patient stroke volume. That's why the group of patients do not benefit too much if they're slowing down the pulse below maybe 60 or 50 heart beats per minute, as compared to the patient with the reduced ejection fraction, and they not tolerate very well the heart is beating too fast either. That's why it's very important to treat the patient with the atrial fibrillation, this special group of patients. And this is published recently, believe it or not, and they found that the patient they have improvement in the diastolic function if the stroke volume is increasing. So this is consistent with which I showed you before. If the patient will have better stroke volume, the diastolic function, I'm not talking about the systolic ejection fraction, I'm talking about diastolic indices, filling pressures are better, and patient doing better with the stroke volume is better for them. Something different, so this is regarding patient with the sleep disorder. I think this is new area, and this should be pointed more probably accurate in our practice as well. So the patient with the suspected heart failure, they should be always look for the patient for the possible underlying obstructive sleep apnea. So it's very important to differentiate central sleep apnea from obstructive sleep apnea. If the patient got the obstructive sleep apnea, they should be treated with the continuous positive airway pressure with CPAP, and they're doing better with this, and this is recommendation 2B, so it's pretty strong. They do not doing well with the central sleep apnea treated with the adaptive servo ventilation because this is causing harm. But as far as I'm aware, no one is doing this in Australia, so it's probably not related to this. So once again, obstructive sleep apnea should be treated with CPAP. Why is like this? Because we are reducing the pressure This is actually related to the whole treatment of the patient with the reduced normal ejection fraction. So our aim is to reduce pulmonary hypertension, because what's happened with the patient with the diastolic heart failure, if the pulmonary hypertension increasing, the right ventricle function decreases, and the prognosis of the patient is worse. There is no data to, recommendation how we should treat this, but in order to avoid worsening right ventricle systolic function, patient with diastolic left ventricular dysfunction should be treated with diuretics, and perhaps maybe even obstructive sleep apnea might reduce this happen, because this is probably one of the worst prognostic benefits. This was published recently as well. It's very complex, telling us why the patient overall will benefit with the treatment with the sleep disorder, sleep apnea. And I would like to draw your attention to the left part of the slides, because this patient with the obstructive sleep apnea got the intrathoracic pressure swing. So they got increased transmural pressure, increased LV afterload, RV pressure, venous load, a subnormal shift of the septum. So as a consequence, this is impaired myocardial, left ventricle myocardial relaxation, and decreased cardiac output. So actually treating patient with the sleep apnea, you might increase patient cardiac output. So this is what we're doing in QCG here together with our clever respiratory physician, Dr. Glenn Rice McDonald. This is one of the patients which we did, for example, and he tried to use the CPAP with different pressure. We found that if the pressure is around 10 centimeters of the H2O, the cardiac output at the time was the best. Probably we reduced a little bit heart rate. That's why the stroke volume was the best. Cardiac output maybe wasn't too good because of the lower heart rate. So once again, it's important to not reduce heart rate too much with this group of patients. Keep the heart rate higher to achieve the best possible cardiac output. But this is what we're trying to do it, and we've got so far pretty good results with this. I would like to tell you also in the end about the anemia. I really don't think so. This is the serious and big problem. Patient might have anemia with failing heart. We know about that very well. I always, from my practice, recommended for the see the gastrologist doing the colonoscopy and upper tract GI endoscopy, because they always got something causing the bleeding. But in theory, they can benefit to have the treatment with intravenous iron replacement. Interestingly, recent studies show there is no benefit for the oral iron tablets, which make not so much sense. This is the diagnosis we call the functional anemia. So actually, HB might be within normal limits, but the ferritin level is lower, and transferrin saturation is below 20%. But certainly, you might pick up in your practice, but as a first line of treatment, I would recommend to see gastroenterologist rather than treat with the iron therapy. There is no benefit, interestingly, there is no benefit to use erythropoietin stimulating agent, RNS, for this group of patients. Actually, it is doing some harm. And the harm is probably related to the thromboembolic complications. The patient might have more thromboembolic problems. So perhaps maybe if you divided group of patients who are already taking a lot of medication to thin the blood, they might benefit, but overall there's no recommendation. Actually, recommend do not use this medication. So I'll put on the summary at the moment. So try to diagnose patient with the heart failure as early as possible, asymptomatic, give advice, treatment for this patient. We can use BNP or NT-proBNP, probably also the troponin, high sensitivity troponin for the diagnostic and prognostic prognosis. We cannot use purely for the treatment. In order to have the proper treatment patient need required echocardiogram to see the mechanism of the failing heart. And you got this all information about valvular lesion, systolic dysfunction, diastolic indices, pump hypertension, RV dysfunctions, all the information is our reports. So if the patient got the abnormal reduced ejection fraction below 40%, we know about very well, you should use beta blockers. If possible, aldosterone antagonists, ACE or RB blockers, we can be replaced with ARNIs today. A certain group of patients might be referred for the ICD or CRT. and small group of patients might benefit from the sinus node blockers. Sorry about that. If the patient got the preserved ejection fraction, it's crucial to treat patient with diuretics. Also treat patient with atrial fibrillation. Check the possible underlying cardiac disease. Perhaps majority of them, or very large proportion, might have underlying cardiac disease, need to be treated maybe with statins or required maybe revascularization. They need it. They might have underlying intracardiac valves. Again, we know about that very well. That, for example, aortic stenosis is a good example at the moment. That we used to say stenosis is severe. It is aortic valve areas below 0.75. Now we're talking more functional. We're talking more even 1 square centimeters. So it's definitely there is some work and there's some new information becoming. Patient got diabetes. Partially, maybe some of the treatment of the diabetes actually could improve patient heart function. So it's a target level, regardless of the patient, reduce or preserve ejection fraction, 130 over 80 beats per minute. Perhaps some of the patients might benefit from the intravenous iron therapy, but do not use the retropoietin stimulating agents. And definitely is the area of benefit for patient with obstructive sleep apnea on CPAP treatment. Thank you very much for your attention.